Right. So I'd like to thank the College of Pediatricians for this opportunity to speak on finding a donor for pediatric liver transplantation. Of course, part of my talk will overlap with the previous speakers' uh, areas as well. So first of all, so before we talk about finding an ideal liver graft, ideal donor, we should speak what is an ideal liver graft. So in liver transplantation, we mainly look for ABO compatible graft, and HLA matching is not done as like in kidney transplantation because liver is a very good immune tolerance, uh, because liver has a good immune tolerance. The next thing is after blood group compatibility, the size of the graft, especially in pediatric liver transplantation, we have to put an ideal size graft, which has enough liver volume to match the metabolic demand of the recipient, but it should not be too big as well. So when you talk about the size of the graft, we talk about graft to recipient weight ratio, which I will talk in my future slides. And also it was further explained by Professor Ram Sirivardhan as well. And also this graft should have a good inflow with a hepatic artery branch, a portal vein branch, and a good outflow via a hepatic vein branch. And also there should be a way of biliary drainage, either via duct-to-duct anastomosis or a hepaticojejunostomy, where we join a bile duct to the bowel loop. And some of the advantages were discussed previously. So with regard to graft to recipient weight ratio, the ideal is about 1 to 4%. So if it's a too small graft, the recipient will have small for size syndrome with cholestasis, ascites, and encephalopathy, and sometimes even the recipient might succumb due to the small for size syndrome. Again, if it's too large, this large for size syndrome comes in mainly in pediatric liver transplantation, because in adults, the native liver out, and in cadaveric donation we put the full liver or part of the liver, but that's never too big. But in children, if it's a too big liver graft, then there can be raised intra-abdominal pressure, and which can affect the ventilation, the extubation, and renal functions. And also there'll be difficulties in closing the abdominal wall. Sometimes we might have to leave the abdomen open, which can lead to sepsis, again delayed extubation and graft hyperperfusion. So that is also something we want to avoid. So ideal graft would be around 1 to 4% of the body weight of the recipient. So luckily, the liver is made of many segments. As you know, each of these segments are supplied by a branch of the hepatic artery, portal vein, and the bile duct. And also the blood is drained via hepatic veins. So we are allowed to design the graft we want. So this is segment 2 and 3. And a graft involving the segment 2 and 3 is called a left lateral sector graft, which is the most common graft that is used for a child around 1 year and slightly above. Then when the child is about 15 kilos, when they are bigger, this graft may not be enough. It will be too small. It may cause small for size graft syndrome. So then we consider taking a left lobe. Again, we design the graft so that there's good inflow, outflow, and adequate liver volume. And for children who are like about 30 kilos or those who are teenagers, sometimes left lobe graft may not also be enough. Then we consider taking a right lobe graft. And sometimes in neonates, this is a left lateral sector graft. In neonates, this may be too big. And in such situation, we might have to take part of the graft, what we call it reduction or hyperreduction, and have an ideal sized graft. So in these situations, the volumetry or CT volumetry is helpful in designing the proper size of the graft. And our radiology colleagues, as they discussed, do a great help in doing proper volumetry of these livers. So how do we get the grafts? So one way is cadaveric donor grafts. So in adult liver transplantation, we transplant the full liver into an adult after taking the native liver out. But in cadaveric pediatric liver transplantation, the graft has to be split into small parts. So generally, cadaveric donor liver can be split into two. So one can be, the large part can be transplanted to adult and the smaller part to a pediatric recipient. But not all grafts can be split. The other option is living donor grafts, which I will talk in the subsequent slides, how we do the donor workup and all that. So regarding cadaveric donor grafts, so not all grafts are splittable. So there are certain criteria. So this has to be a good graft to split, because otherwise, if we split a marginal graft, the graft might not work once we reimplant. So this sort of a donor has to be less than 40 years, BMI less than 28. The liver function should be less than 3 times the upper limit of the normal, and they should be on single or minimum vasopressors, short ICU stay. But in the Sri Lankan context, the most of the donors, like in our general population, they have fatty liver disease and they have obesity. And on top of that, in Sri Lankan, cadaveric donor offers come a little bit late to us, because they take a lot of time in diagnosing brainstem, because they decide to do the brainstem testing fairly at a later stage. And once it's done, the consenting, all that takes a period of time. And by the time they are offered to us, the donors are on more than 2 vasopressors. The ICU stays definitely more than 3 days. And with the background fatty liver disease and all that, most of the donor offers that come to us are not splittable. Very few will be splittable offers. Even if they're splittable, we have to do this in an unfamiliar setup, because we have to go to the donor hospital and the split will be done in a unfamiliar place where there's no proper equipment. So split liver graft in Sri Lankan setting is slightly difficult compared to the living donation, but it had been done. The other option is living donor grafts. Again, we look for ABO compatibility in most of the time, but there are situations, younger patients less than 1 year, where we have done ABO incompatible transplantation as well. And these are the criteria of an ideal donor. The donor has to be less than 45 years, BMI less than 25, and there should not be any comorbidities, and they should not have fatty liver disease. But of course, in certain situations, we might have to expand this criteria and consider some of the donors as donors, those who are out of this criteria. But this is what we would prefer to have as a donor. And also in living donation, unlike in living kidney donation, there's a significant donor risk. There's about 1 in 1,000 donor mortality risk. So all this is explained to the donor at the time of the initial screening. And we also would prefer to have some degree of relationship with the recipient, but according to the Sri Lankan law, it is not necessary. And some of our donors have been meditating monks who are altruistic donors. Then once they do the initial screening and there is consent and all the criteria are fulfilled, we do the donor workup, which includes CT of the abdomen, MRCP to look at the bile ducts, and then we do a volumetry and also do extensive cardiac, respiratory, and psychological assessments to make sure that the donor is suitable. So once all that is done, the donor and the recipient is sent for ethical approval. But in situations of emergency liver transplantation for acute liver failure, sometimes we get the approval from the Director General of Health, DG, directly without waiting for the ethical approval. And sometimes we have been able to complete our donor workup, living donor, within less than 24 hours in 2 situations, leading to successful pediatric liver transplantations. And then once all this is done, we fix the surgery where the donor and the recipient is done side by side simultaneously. And in our experience, we had to work up about 3 donors for each living donor liver transplant we have done, because either the donors were rejected because of abnormal biochemistry, abnormal anatomy, or other ethical issues. But in our limited experience, the transplanting with living donors had been successful than with split liver grafts. So in summary, in the Sri Lankan context, finding a donor is a challenge because in living donors, there are a lot of fatty liver disease, comorbidities, and also the parents who are initially worked up for as the potential donors, they generally have, by the time they reach their 40s, they have diabetes, obesity, and other medical problems. And also, split liver grafting had also been challenging because of the delayed offers and logistics of doing liver split in peripheral hospitals. Still, with all these challenges, we have been able to perform 14 pediatric liver transplants successfully. Thank you.